Hello and welcome everybody to Health Tech Nerds Discussions. We have Lawson today from the Niskanen Center. Lawson, would you mind starting and introducing yourself?
Yeah, of course. So Lawson Mansell, I'm a health policy analyst at the Niskanen Center. Prior to Niskanen, I primarily worked at the state level. I'm from South Carolina and sort of started in this actually working with doctors on policy related to direct primary care. We work with DPC doctors who were trying to open an ambulatory surgery center in rural South Carolina and were shut down due to certificate of need laws, which was sort of, I guess, my kind of awakening on healthcare policy, or radicalization, you could say, realizing all of the things that got in the way of doctors that wanted to care for patients, even in rural areas. So since then, I've sort of been loosely connected to the healthcare world, worked at other think tanks, but at Niskanen, for the last 2 years, I've been working directly on healthcare supply issues and how to ensure that we can get enough doctors and hospitals to areas of need.
It feels like it's one of the most important and timely conversations. I was wondering if you could start by setting the table for us a little bit about what are the unique challenges of primary care in Medicaid? What are the access issues? What are the problems from the physician side? What does that look like?
Yeah, so I guess to start out, kind of talking a little bit about primary care, I think I guess one of the main issues is sort of what I would call like the financial viability of primary care. I think over time it's become harder and harder to run, particularly to run an independent primary care clinic. I like to kind of think of like the provider market in healthcare as like on like a spectrum of sort of like ownership, I guess you could say, where like on the far left you have these big hospital systems that own a lot of different clinics, buy up primary care clinics, buy up surgery centers, and sort of put everything under their kind of hospital model. And then on the far right of this, you kind of have like an urgent care center in every strip mall. And that's new. Like 25 years ago, it wasn't like that. There wasn't an urgent care center next to every TJ Maxx where you could kind of go and get basic primary care done by an NP or a PA. And a lot of that has been scope of practice laws enabling, where an urgent care center, you just need one MD essentially, and that MD doesn't have to be there sometimes. You have a lot of states that have sort of flexible rules on that. But what's missing is sort of I say the middle, which is kind of the independently owned primary care clinics, ambulatory surgery centers, where folks can get care at the same or better quality than the big hospital system or the urgent care, um, but obviously can get it for less expensive, can get it for a better deal, can get a better deal there. And I think in particular, in the conversation we'll get into today is more about the primary care setting where, what's missing is sort of the relationship-based primary care. You don't get that at an urgent care center in the same way. They're not designed for relationship-based care. And it's really hard to get that in the big hospital system as well. So, I think because it's been harder and harder to run these clinics and they've been disappearing in America, we need to think of ways to make them more financially viable. And Medicaid is a great example where Medicaid patients often are going to the emergency room rather than going to an independent primary care clinic to get their routine care needs met. And this is not the best setting for someone with chronic conditions. So, the kind of the question is, how do you restore the missing middle of independent clinics, clinics that can offer a better deal for patients?
Yeah, I think one of the things that's so interesting about that is that there's this like circularity to it, which is like Medicaid reimbursements are low. It's kind of like a drag to get in network with Medicaid in a lot of states. And so you have not that many primary care doctors who are already the lowest paid doctors that we have in the US, not wanting to go serve the Medicaid population. And then those patients are ending up in the ER, which is an extremely reliable place to get medical care, but also one of the most expensive sites. The other piece of this that I think is really interesting, and you've been doing a ton of work on, is on the DPC front as just a policy matter. For folks in the audience, like I feel like there's a lot of confusion about what constitutes DPC or direct primary care and what isn't. Can you kind of give us the definition from your view?
Sure. Yeah. So I've been kind of working with DPC docs and on the issue for 5 or 6 years now. And I think there's been a lot of changes. One of the main changes is the model has exploded. But I think one of the misconceptions that a lot of folks have about DPC, I think this is particularly true of folks on the left more than it is folks on the right. But the misconception that it's sort of concierge medicine or like medicine for the wealthy or the privileged. And at one point, I think the only folks kind of doing this sort of independent, don't take insurance model were likely concierge doctors, doctors that kind of cared for the rich and famous, would go to your hotel room, would go to your house for you and take care of things. Those doctors, of course, still exist, but the DPC model is something entirely separate. The only real similarity is that they often don't take insurance or they don't have to take insurance. That's really the only similarity. DPC doctors now, set up these clinics and oftentimes are charging 70, 80, 90, around $100 a month. It's obviously increased over the last 5 years with inflation, but you're looking at between 80 and $100 a month usually. And with that, you get kind of unrestricted access to your doctor. Every DPC doctor does it a little bit differently, but all of the ones that I've either had as a patient, been a patient of, or talked to, usually give their cell phone number out, and usually, have like I think 99% have walk-in appointments. You don't even need to, get an appointment 2 months in advance or think that far ahead. And it functions as both like an emergency room and an urgent care sometimes. In an emergency room, not in the sense of like a major, issue, but like the things that Medicaid patients tend to use emergency rooms for, which is I don't feel so well, something's happening. With DPC, folks can walk into those clinics. I think the other unique thing is you can also get medication at lower costs. Oftentimes, DPC doctors can get medication at wholesale rates. And every kind of subscription service is different. So, in some cases, you could pay a little bit more and get access to more if you're sort of a high needs patient. But it's different. So, yeah, I think the main distinction is you can walk in, you have walk-in appointments, you pay a monthly fee, you don't need to use insurance. And then what patients tend to do is then kind of have a high, sort of catastrophic plan that they kind of tie in with their DPC model, and that's kind of what they spend their dollars on.
What does that look like from the doctor's perspective, I guess, really quickly? And then I want to move into Medicaid. But
Yeah.
it intuitively to me, it seems like, okay, I don't have to deal with insurance. I'm getting a subscription payment, monthly recurring revenue or annual recurring revenue, which is nice. And one of the things when you talk to Medicaid patients on why they're using the ER is like, well, I have a hourly job that I work. And so the doctor's office is closed when I want to go to the doctor, but the ER is always open. And so, yeah, what does that look like from a doctor perspective?
Yeah, well, it seems like, well, I think one of the main reasons that DPC, the model, sort of exploded over the last few years is because of the increasing like difficulty. I mean, you have so many things happening in the, the market for doctors. There's burnout, obviously, because doctors are being asked to do a lot more than they were before. They're being asked to handle a lot more paperwork. They're not getting to spend enough time with patients. And then I think on the other end, you also just have more big hospital systems buying up clinics and and obviously, if you're a doctor, it can be attractive to get purchased by one of these hospital systems because you can make more and they may take some of the administrative stuff off your plate. But most doctors go into this, because they want to care for patients. Like that's the truth. Doctors didn't go through 11 years of training and the difficulties that come with that, to not care for patients. So I think what's happening is doctors are choosing this model. They're realizing that they can actually create a clinic that's financially viable, and they can spend all their time caring for patients. And I think that's the key thing is when you can take whatever percentage of their time they're doing paperwork, take that out and basically replace it with patient care. Um, I think they're happier. I think that's one of the big survey results is doctors just are less burnt out in the DPC setting. And two, I think you can actually make money because you're bringing more patients in. You have time to actually care for patients, um, and try to recruit and get folks on your panel. So anyway, I don't really know if I answered your question very well,
Yeah,
but
yeah, yeah.
one of the main things kind of driving doctors to those settings.
So you have been doing some work on a bill that's in Congress, correct? Medicaid
Yes.
Primary Care Improvement Act. Give us an overview of what that looks like. What would if that bill sort of makes its way through the Senate, what does that bill do?
Yeah, so this bill passed the House last year, which is a really important thing to note. It unanimously. So this is not a controversial idea. Most of the questions just trying to get folks to care about it. But this is a bill originated in Congressman Crenshaw's office, and co-sponsored by Congresswoman Schreier. It's a bipartisan bill, and then just 2 weeks ago in the Senate, it was reintroduced. So bipartisan as well. Senator Marsha Blackburn and Senator Mark Kelly in Arizona. I've introduced it. The idea is that, we have all of these Medicaid patients that are going to the emergency room, going to sort of what I would call hospital emergency room is like the gateway to like unnecessarily high healthcare spending. That's where Medicaid patients are going. And the question is, how do you ensure that Medicaid patients can access routine primary care? Like you mentioned, really difficult to get networks robust enough where patients have good access to primary care. And so the idea is like, what if DPC clinics in a state partnered with their Medicaid program, wrote a contract either with the traditional Medicaid program or with the MCOs in that area, and said, hey, we have a group of primary care doctors, we come together, or you just have fun one clinic, you write a contract, Medicaid pays the small, 80, $100 monthly fee. They negotiate that rate. And then you just tell the patients, hey, you can go to this doctor, no cost sharing. You can go as much as you want, get relationship-based primary care. And evidence shows that it reduces emergency room. And in so doing, it saves money. One of the main barriers that states have to actually like creating these arrangements is they have to file for what's called Section 1115 waivers with Medicaid. Those waivers historically have taken a long time to process. I think this administration would be more likely to process them a little bit faster for something like this because DPC is something that this administration has supported. Um, However, it's still a hurdle at the state level and a hurdle at the federal level. And when you have two hurdles at both the state and federal level, you introduce a lot of wasted time. And so what the bill does is it just removes the requirement for any waivers if a state wants to create these kind of arrangements. Because technically under current law, it's illegal to do it without a waiver. And so it would essentially make it legal, where states, if they wanted to, could partner with these clinics, could start creating these arrangements, writing up these contracts, and sort of testing out a pilot program.
Have any states tried this yet? Is there any sort of track record here?
So there's sort of been different things that have happened. We have one state that's sort of tried a version of this, Michigan in 2018. They filed for a waiver, got the waiver. It took a little bit too long, so it cut into the time of where the pilot could run. But and they got like 350 patients onto DPC doctor panels. The pilots seemed to save money from what I can tell, reading through the documentation. Small, it's kind of a small thing, but they weren't able to get it funded again. And so, I know just from conversations with CMS directors in the various states that there's a lot of states that would do this if the bill passed. So we
Great.
know it can be done. Another thing is you have some DPC clinics themselves that have figured out a way to get Medicaid patients on their rolls. I know in Ohio, this has happened successfully. But the transformational potential is at the state level with the traditional Medicaid sort of office saying we're going to prioritize this.
So my first experience with DPC, it was actually when I was working for Colorado Medicaid. The state of Colorado had a DPC relationship
Cool,
with what
cool.
was then Paladina, is now Marathon, and I thought it was awesome. And so it's kind of cool to see this come around. I think one question I have is like, so my intuition is that I think part of the draw, and you talked about this earlier for a doctor, is that a DPC relationship is nice because you get the money and you do the doctoring and you're not spending a ton of time doing paperwork and quality stuff. Like you're able to operate a low overhead clinic without a ton of administrative fuss. And when I think about state Medicaid agencies or government contracting in general, like I kind of that's not my association with.
The opposite, yeah.
So what in your view, what would that kind of relationship look like? Would it basically be a a payment that the Medicaid beneficiary can kind of they can go out and choose a DPC who's like opted into this, and then it's just like a payment that is from Medicaid directed by the patient and then to the doctor, or what would that look like?
Yeah, so I think there's different ways to imagine this. I know folks have sort of had this idea of like sort of, I don't know, just being able to like have patients sort of direct the funding more. And there's been some developments on this front in the OBBA. Now you can use HSA dollars to pay for DPCs. There's a sort of idea now of like FSA dollars. There's all these kind of different options. What this bill primarily does is it leaves everything to the state. So
Cool.
the idea is that you don't want to be too prescriptive at the federal level of what this looks like because we know because of the MCO world, every state's going to have a very, very different looking sort of marketplace. Not only in terms of like some states are going to be dominated by MCOs, other states are going to have a lot of like traditional Medicaid patients, but also every state has very different sort of like DPC configurations. Like there's some states that like a lot of DPC doctors are under kind of like an umbrella organization that then can contract on behalf. That happened in Michigan, where essentially like there's a lot of DPC clinics in one area that were all kind of owned by the same umbrella organization that then contracted with Medicaid, and that worked out really well. And I think you could see something similar, um, but it doesn't force this on anyone. It doesn't force it on any states. It doesn't force it on any doctors. Every doctor could kind of decide individually if this makes sense for them. DPC doctors are largely in favor of this, but the main concern that you mentioned is the paperwork. Like the whole reason why they want to get into this is so they don't have to deal with paperwork. And then you're talking about Medicaid, which to them screams paperwork. So I think the most important thing is one, I think you're likely going to see probably states without as much MCO participation more likely to kind of drive this because if you think about it, if it's a state CMS administrator that decides, hey, I want to jump in on this, I want to start a pilot, I want to kind of be like a state that's forward looking, um, likely it's going to be like the state CMS themselves that are excited about it. And they're the ones that are going to want to get folks kind of involved and tell them, hey, you can go to this doctor, reach out to folks. Um, Getting the MCO to get excited about it and start contracting is a different world. And so I think that's one thing is you're likely going to see that. I think the other is you'll likely see DPC doctors try to get contracts with MCOs where the MCOs handle a lot of this stuff. I mean, I don't see a world in which a DPC doctors want to get in contact with the MCO where they have to deal with all the data reporting, the quality standards, all this stuff. I think most of it would be there's going to be some push and pull. It's like, okay, maybe we'll pay a little bit, we'll take a little bit less of like a per month sort of payment if you handle some of this data reporting. And I think you still have DPC clinics coming out in the green, even in an arrangement like that with an MCO. Um, but there's definitely going to be, there's no world in which I think DPC doctors are just going to be willing to take on all this new paperwork and data reporting. I think they're going to have to figure out ways to either let CMS handle that, uh, or let the MCO handle that.
Yeah, it feels to me, and, I was just pulling this up, but I think like with Centene and Molina, who are the two of the larger MCO operators, their revenue per month on average is like around $500. And you can imagine them. I don't know if this is the case. Actually, let me just ask you, is like, do you hear or see any pushback from the MCOs that this is kind of like um, messing with their formula, which is like all around utilization management? Or on the other hand, are they excited about this as a potential lever that they could pull?
Yeah, we've gotten no pushback from MCOs, at least not that I'm aware of, on this. I think a lot of it is because all of this is voluntary. Only the MCOs that are excited about it are going to participate. So if there's MCOs that don't see the vision and don't think they have a market for it or don't think it makes sense for them, then they're simply not going to participate. I think there's an open question of how this works in terms of how the Medicaid program talks to the MCOs, how they advance this. But I think the goal of the legislation is to ensure that the only people participating, the only people that are engaged in these agreements are ones that are, enthusiastically supportive on both sides. Because, that I think that's the only way this works is if there's a huge amount of incentive alignment on all sides to try to, first of all, you have to tell patients about this, and then the hardest thing in healthcare is getting patients to change their behavior, right? Like the price transparency is a big conversation, but we don't have any evidence yet that price transparency encourages people to make different decisions in healthcare. So um, the question is, how do you alert your members? How do you alert your Medicaid beneficiaries? I think it's going to come down to very, very direct engagement, saying, "Hey, this clinic in your county, you can go there and get primary care without any cost sharing as much as you want. And here's how you do it. Like we've signed up for you. All you have to do is opt in. You're already it's easy. They have to make it easy. It has to be incentives have to be aligned for everyone.
It is interesting too. So one of the areas where cost sharing has always been, or not always, but recently been allowed, even before the One Big Beautiful Bill Act, for Medicaid patients is ER utilization, and some states have done some interesting things. And so you could imagine a world where you're saying it's like, oh yeah, you have a cost share if you go to the ER, but if you use this, um, whether it's like an app or a phone number or just like, instead of go not to the hospital, but here, or for a telehealth appointment. Like that's like a kind of a compelling thing that
Totally.
might be able to push. So one of the things, though, that the other sort of flip side of this is we're entering circa 2027 a sort of tighter funding environment for Medicaid with the One Big Beautiful Bill changes to the provider tax, state directed payments, et cetera, et cetera. Um, I think that could cut both ways. Like I could see a state saying, okay, we need to try some radically new things. Like the way that we've historically done things is not going to work going forward. I could also see it going the other way, which is saying like we don't really want to try anything right now because we're freaking out. I'm curious. Yeah, I'm kind of curious if you've heard any feedback on that or have any sense for how states are thinking about this.
Yeah, I mean, to be honest, I do think, despite this being a bipartisan bill, I think you're more likely to see probably red states be open to taking this up, considering the sort of like administration support of this. I think there's going to be a strong incentive if you're a Medicaid director at the CMS level and or if you're a Medicaid director at the state level and you see this being pushed at the administration. RFK has already come out in support of this bill, by the way. So like this has sort of administration support. There's an incentive for you to create a proof of concept, right? Like, so I think you're going to see some red states get involved there, despite sort of some of the funding things. And then I think to your point, because this is sort of a small fix, even if a state creates a program, gets, I don't know, 12 DPC clinics to sign a contract, we're not talking about a lot of money here. And so I think, not only obviously is there savings potential, but I think it's not as much of a risk if this were a more widespread or a bigger dollar amount. And so if it's with a small amount of risk, but with a huge potential for like transformation, if this goes well, I don't think there's a whole lot of funding issues that are going to prevent states from getting involved. I think it's going to be more likely a political one than a funding one on something like this.
Yeah. The other thing that occurred to me, and I'm just kind of spitballing here, but it's a sort of a shame that this bill is still pending and the rural health transformation program stuff, like those applications have always gone through because you could imagine with some of the flexibilities like financing a pilot project where you have, sort of a catchment area in a rural area and a community doctor and sort of helping bring a community doctor who's going to do DPC to a rural area for like a larger area. Like that would be, I think, a really great thing for to try and experiment with.
Yeah, it would have been a really good thing to include. And honestly, I think this bill would have been in the OBBA. It was in sort of an early draft. The problem was, with the bird rule, it has to either save or cost money. And so this is a cost of $0 at the federal level, and so it
Yeah,
wasn't eligible. But this is something that would have been in there. So we're pretty confident that we could see it pass in the next package, with support on both sides and support from the administration.
cool. Yeah, it does seem like there's going to be some vehicles for it. There's a couple of healthcare bills percolating at the
Totally.
moment. Okay, so another limiting factor to this idea, which I think is really compelling of DPC and Medicaid, is we have a primary care shortage in the US, which is something I know you know a lot about. The average DPC panel size, from what I see, according to some literature, is about 400. A doctor at a hospital might have a panel size of 2,000, and so that's obviously a lot fewer, though perhaps like a lot higher quality. I'm curious what your view is on what we could do to address that shortage.
Yeah, it's true. It's an interesting sort of wrinkle, the reality that a DPC doctor is going to be seeing less patients. But I think we do have to sort of acknowledge the fact that relationship-based primary care is the primary solution to the kinds of issues that Americans deal with primarily, which is chronic conditions, obesity, um, you know, chronic health issues that kind of require routine maintenance, that require honestly like some lifestyle changes, obviously. I mean, it's something that's obviously in the conversation with Maha. And it's really primary care doctors that do that kind of work. Obviously, you can have a bully pulpit and tell people to eat more vegetables, but it's very different than making sure you have sort of a relationship with a doctor who knows your specific health needs and can give you specific advice on how to manage that. Because the most important thing is that you're able to take someone with chronic conditions and make sure that they don't spiral out of control. It's difficult to prevent someone from developing these conditions because a lot of that is lifestyle. A lot of it is honestly dependent on where you live, the kind of food you have access to, and choices you make. But having a doctor that can help you take those issues and make sure they don't turn into something that's life-threatening is what primary care doctors do. That is their job. And so, uh, regardless of the patient panel size, I think DPC doctors have sort of a really unique role there, a really critical role. So I think I would love to see more doctors leave the hospital system and start a DPC clinic, because ultimately I think that's best for population health to be able to for patients to have access to an appointment that lasts 30 minutes versus a 10-minute appointment. I think that changes things. Um, I think the other question is sort of large, like bigger picture on the doctor shortage. The solutions tend to be either focused on sort of like pipeline or regulation, and I think both are involved. Like I think when it comes to pipeline, we're not producing enough residency slots, and this is something that you know all it does is put more pressure on doctors. It puts pressure on DPC docs, it puts pressure on hospital docs because we're not producing enough to keep up with demand. And then on the regulatory side, we also have a bunch of licensing restrictions all across the country that sort of keep people practicing below their training. You have immigrant doctors who are required to get a US or Canada-based residency if they want to even get licensed. And so you have a ton, thousands of doctors across the country that are taxi drivers, janitors, run businesses doing other kinds of things below their training, usually doing medical coding or they're even serving as PAs when the reality is they have been doing general surgery for 20 years or providing primary care in a rural community in Turkey for 15 years and they move here and they can't do it. So relaxing some of those rules, creating pathways for those doctors, ensuring that licensing standards match the kind of training that doctors get. All of that stuff helps. I mean, you've seen the scope of practice change the world for urgent care, with letting NPs and PAs do more primary care. So, I think if doctors don't want PAs and NPs to be doing more, then we need to be thinking about other ways to make primary care more financially viable and get and create more pathways for international doctors.
There is this kind of funny, there's a startup in Minnesota that was running DPC with like all NPs because in Minnesota, NPs can practice independently, which is a cool called Nice Healthcare. And then I know that there's maybe one of the Dakotas or Montana or Wyoming where PAs are like they've been running a PA licensure piece. And yeah, it's like we just need more doctors, and if we don't have more doctors, then we have to start taking people who are not doctors, and that might be a international doctor, it might be someone, but that is kind of the problem here. Okay, last question because we're about at time. One of the things you and I have talked about offline is, the topic of the day right now is how expensive insurance is,
Yeah.
and I'm kind of one of the things that I find fascinating with the DBC model is that like you're spending money or the government's spending money in the case of Medicaid, but you're getting like a relationship out of it. And so I'm kind of curious to hear your long view on this of whether there's some sort of compromise to be made where but maybe it's like a high deductible plan plus a DPC account or something like that.
Yeah, I think there's a lot of folks in the administration and otherwise that like this is sort of a vision for healthcare, right? The idea that um, it doesn't make financial sense for insurance to cover primary care in the same way that car insurance doesn't cover your oil change, it covers your accident. I think that there's a lot of folks that sort of identify with this idea. particularly primary care doctors who have experienced it, right? Who have experienced their inability to run an independent clinic and have had to sell to a big system or have had to leave and open up a TPC clinic. Um, so I think that's a really compelling vision to the idea that, what if primary care could be $100 a month, and then I can have a high deductible or I can have a catastrophic plan to take care of everything else, because I'm a relatively healthy person, or maybe my issues are mostly chronic, and all I need is someone to help me manage that and make sure I get my medications cheaply and make sure that I'm doing the right things, I'm doing my exercises. I think that's really compelling both at the patient level and at the policy level, because uh, with insurance premiums out of control, you want an answer that brings that down, and I think something that does that is by putting less pressure on the insurance market when it comes to primary care and pivoting into something. Obviously, we're at the very beginnings of that, but I think it's a compelling vision for sure.
Yeah. I think, it's one of those things where healthcare is expensive in the US because healthcare services are expensive. DPC, you're sort of stripping away a lot of those layers. And people hate high deductible plans, but they're in some ways policy optimal for getting people to experience, like not having first dollar coverage. And so it seems like a reasonable compromise to me. But
Yeah.
we're now at time. I apologize. Lawson, thank you so much for your time. Where can people find you, follow your work on the internet?
Yeah. I'm pretty proficient poster on Twitter, so feel free to follow me on X. It's just my name with my middle initial H in the middle. Or niskanencenter.org is where we post all of our research and commentaries.
Great. I will link to this in the show notes. And thank you so much. Have a great rest of your day and have a great weekend.
Yeah, thanks, Martin. Happy holidays. See you.
Bye. Bye.